course, I wore the blazer with the buttons. Ah,
It's going to be loud.
You're live.
whatever. Good evening, everyone, and welcome to the third annual Opioid Town Hall with the Martin County Department of Health and Human Services and Martin County Board of County Commissioners. My name is Micah Robbins. I am a member of this fine community, most importantly, father to River and Lola here in Hobe Sound, but I'm also the director of special projects for Palm Beach County Behavioral Health Coalition, as well as a member of the Martin County Community Action Coalition. Tonight, we are gathering to discuss the ongoing challenges with opioids in the community. We're going to be looking at trends, solutions, and the ways we are addressing this issue. We have an esteemed panel with us tonight that is going to be engaged in a conversation about these issues, and very pleased to introduce them tonight. So we welcome all of you that are live on Facebook. We welcome everybody that's joined us live here in the room. If you do have questions that you'd like to ask of the group, please submit them via the comments on Facebook, and we will get to as many as we possibly can. Thank you for joining us all. We hope to have a great conversation tonight. We hope that you all learn something, and we face this together as a community. So, with our introductions, we have Chloe Miller, probably one of the most important people right in this conversation. She's a person with lived experience in recovery, and we welcome you tonight.
Thank you.
Dr. Jay Kuchera, who is an anesthesiologist here in Martin County, also an expert in this space, and has been part of many, many of these conversations specifically, but also is a tremendous resource to a number of community groups when discussing the issues of opiates and their uses, and especially how we utilize them in appropriate and safe fashion. We have Chris Camel, who is the Bureau Chief of Martin County Fire Rescue, and also looking quite dapper tonight. I'll make sure that we put that out there. Yeah. Not to say that Captain Bill Dowdy is not, but Captain Bill Dowdy is joining us tonight, of course, from Martin County Sheriff's Office and the tremendous work they do there. And finally, to our right, Dr. Aneshka Marshall, who is the Chief Clinical Officer for Tykes and Teens, which is our agency that works with youth and families in the behavioral health space here in Martin County. And again, a tremendous resource for a number of different programs around here. So you have the group that can really get at this issue, and we're very pleased to have all of you here tonight. And how this goes for those at home and for those that have been part of this in the past couple of years, this really is more of a conversational piece. I have a number of questions I'm going to ask the group, and certainly the folks that I ask them to. We're going to have some responses and some dialogue there, but also anybody on the panel can respond and be a part of any of these conversations, because quite frankly, they're all intertwined as we go. And tonight, I actually would like to open, I think it's actually tradition now, with Bureau Chief Camel, and looking at our current, with fire rescue, and looking at our current trends that you're seeing out on the road, out in the streets in Martin County when it comes to the opioid crisis, what you're seeing in overdoses, and also what are you seeing as primary sources of those overdoses?
Excellent. Thank you very much. In Martin County Fire Rescue, we treat a lot of people for emergencies in the field. We get to them, they're unconscious, unresponsive. We administer Narcan. We go through the whole process of ALS care before we get them to the hospital. In 2021, we saw a bit of an uptick from 2020, I think just because of the pandemic and what have you. And last year, our numbers were, we had 137 up until August 1st, from January 1st to August 1st. We had 137 suspected overdoses with 126 that we actually treated. Of those, 93 responded to the Narcan, so it was in fact an opioid. And of that, 67 not only responded, but were unique patients. In other words, just 67 unique patients out of 126 suspected patients. So a lot of repeat patients. This year in the same time frame, looking exactly the same comparison, apples to apples, we had 136 suspected. But of those, only 78 received Narcan, so they weren't actual opioid or suspected opioid. And of the 79, we had 60 that actually responded to the medication appropriately, and 43 unique patients. Overall, it's about a 30% drop in opioid overdoses and suspected overdoses for the year thus far. So it's definitely a decrease, and I think a lot of that has to do with the pandemic and the actions from OD2A with Michelle Miller and all the different programs that we have in Martin County. So right now, things are on a downswing, but we still see plenty of it. There's always new medications out there, new drugs out there, and it's always a challenge to be prepared for whatever, comes our way at this point in time. But we're making inroads, and that's a good thing.
And it does. See those decreases is great because we're not seeing decreases in all areas of the state as well. So this is really important. You also mentioned the distribution and usage of naloxone, and how important of a tool has that been, especially for folks that don't really understand maybe what that is?
It's starting to catch hold a little bit in Martin County, a little bit better than it has been in the past. This year I gave out more Leave Behind Narcan than I have ever given out before. Leave Behind Narcan is a nasal spray for Narcan is a narcotics antagonist, so it'll alleviate the symptoms or block the symptoms of an overdose when it's opioid related. And we hand those out to people who are at risk and people who work in fields that they are in touch with at-risk people or have family members who are at risk. And we're seeing a lot more of that in the field. I don't have numbers on that, unfortunately, because it's not always something that's documented. But I'm using a lot more, and I have a lot more people coming in as repeat people. Hey, I used this the other night. I'd like to get some more. And so we're handing it out to anybody, and it's actually advertised online. You can find us as a resource. And so we hand out, I have at least 100 doses in my office right now. So it's definitely a very good tool for those who are at risk. It's not an enabling thing. It doesn't enable people to do so. It protects because people are going to overdose until they decide they don't want to overdose anymore, until they get the help they need. Our job is to try to keep them alive until they finally cross that barrier that allows them to get the help they need and make it stick. So that's what Leave Behind Narcan is all about.
Yeah, so it's a tremendous resource. And again, there's a lot of, you mentioned OD2A, the Opioid Data to Action initiative that's happening here in this county and other counties around the state. Education, outreach, those types of things seem to be working in your mind.
I believe so. The numbers show that.
Absolutely. Follow up on that. When it comes to the responding opioids that you're seeing, do you have the reports of what that was in the system? So as far as people hear fentanyl all over the place. Mm-hmm. Are we seeing synthetic? So what are you seeing that?
We don't really chemically analyze it.
Okay.
We just know they respond to Narcan, so it's definitely an opioid. And what we see a lot of, we see groupings, so it seems like a batch that's really high in fentanyl, I would imagine. That's just guessing that, but it's certainly the numbers shake out for that. That's higher in fentanyl, which will lead to more overdoses that we actually get called to the unconscious unresponsiveness. But Sheriff's Office may have those numbers.
Actually, I was going to pivot right to Chief Dowdy. Especially in the space of interdiction and looking at what you're seeing taken off the street, can you give the community a little report of the state of where the Sheriff's Office is?
Well, our calls are down for overdose as well, the same as fire rescue. Right now, we're right about 59 calls for the year. Compared to last year, we were at 144. Our overdose deaths are half of what they were last year. One of the things that we are noticing at some of these calls that we go to, our repeat calls, are they have their own Noxolone, they have their own Narcan on hand. That's a good thing. It's there for them, and people are utilizing it. As far as the numbers, there are numbers. The medical examiner, he keeps track of when OD deaths come in. He differentiates whether it's actually an opiate or something else that was in there. I don't have those numbers with me, but there is a breakdown on those numbers. The fentanyl deaths are, Doc, you may be able to have more information. Maybe you're familiar with it. I don't believe they're as high in total as some of the others that are there, or that they're astoundingly higher than the others, but they are there. It's definitely a positive impact. It shows itself.
And as far as other substances that you're seeing being confiscated or in arrest, are you seeing any changes across the landscape of what we look at, sort of a profile of what our substances are across the county? Are you seeing any changes in the profile? Are we still primarily opiate, or are you seeing inroads of other types of substances?
We're seeing inroads to where people are actually requesting the fentanyl. And our street sales, we have that is what is being offered up and ordered up by our users and our suspect dealers. They're trying to get the fentanyl. There's, as far as the designer drugs go, there's some that we've all talked about. We've talked about recently. Martin County is unique in the fact that we're not Palm Beach. We don't have the influx, so things are a little slow to get here. Doesn't mean it's not going to come. It doesn't mean it won't be here tomorrow, but it's just not here today. The drugs that are out there, people are asking for heroin. When it goes to the lab, we get it back. We find out it's actually fentanyl.
And you also mentioned things are slower to get here, but there's also that value that you can see what is happening around, be predictive and proactive as well, and be able to make preventative moves to keep those things from happening. I think that's really important. People understand how this county is engaging to reduce those chances of those substances getting here, which is great.
It is. Our narcotics unit, we actually have detectives they focus on using E-Force and other items, trying to track down not just the narcotic-related usage, but also where it's coming from, especially when we have an OD. We try to track it back to the source. Those cases, trying to prove those cases, it hasn't always been successful. There's a lot of hands involved in it, but it's something that we do our best to get to the root cause of it.
And Dr. Kuchera, we know about emerging substances. Of course, 3 years ago, we were just discussing fentanyl. Now it's kind of the common vernacular, and knowing that those compounds continually adjust and get reformulated. What are you seeing as some of the emerging trends or some things we should be on the lookout for?
I think this already emerged years ago. So it's post-emergent, meaning synthetic opioids are basically commonplace. The synthetic opioids like fentanyl and the fentanyl analogs have replaced heroin in most of the communities in the United States. If you look at the provisional overdose data from NIDA and CDC for 2021, they had about 107,600, and that's provisional. So this is subject to a little bit of review, but it's pretty much, we got about 108,000 overdoses. And of that, about 57,000 were synthetic opioids. So the lion's share right now is synthetic opioids, mainly fentanyl, but, fentanyl and the fentanyl analogs. I'm looking right here, 2019, 76% of analogs were carfentanil, phenylfentanyl, acetylfentanyl, 4-fluoroisobutylfentanyl or parafluoroisobutylfentanyl, cyclopropylfentanyl. It goes on and on. There's over 1,000 different synthetic opioids. They started getting manufactured in 1950s. A lot of them got filed away, never went to patent, or they were patented and never went to production. It's such a dynamic landscape right now. The drug supply changes. Heroin is diacetylmorphine, so it's a modification of a morphine molecule. You're not going to see much heroin anymore. So everything is fully synthetic opioids. Things like, I don't know if you remember back a few years ago, U47700 hit Sarasota, had some deaths there. It was pressed into counterfeit Xanax, bars. But, I look at it like the synthetic analogs. When we say fentanyl, that's a catch-all term for a variety of different molecules. It's like vehicles. You have buses, and you've got trucks and SUVs, you got sedans, there's like a little mini compacts, there's motorcycles, mopeds. Those are all the different opioids out there. Some of them have very high affinities. Carfentanil is extremely toxic. That's like a Big Mac truck. And then, you've got everything on down the line. But, to say fentanyl is kind of like saying like a Toyota or what, an SUV, that certainly doesn't capture all the vehicles out on the road. So fentanyl's like now a catch-all term. Most of the stuff that we're seeing right now is fentanyl or fentanyl analogs, but there's a lot of other stuff. Isotoniazine came and went. It emerged in 2019. It kind of faded out. So the market is very dynamic, and the life of a synthetic opioid, a lot of the pressure on that has to do with scheduling and classification and pressure on production, of China's manufacturing a particular opioid, and it gets scheduled. It's such a difficult policy game to have it put on the Schedule 1 and then go to the country and start leaning on the production, and like the designer drugs, they just shift around. I mean, if you look at the difference between like a Camaro and a Firebird, it's like back in the day, just a tiny little change in the molecule, one would be scheduled and illegal and the other wouldn't, yet there's minor changes. I'll put a little methyl group here or, change the hydroxyl group or whatever, and you have a chemical that's not scheduled and not recognized as illegal. But for the community, the take-home point is synthetics are here. They're oftentimes significantly more toxic and deadly than heroin. Fentanyl, the lethal dose for fentanyl, which is like the granddaddy of these, is about 10 to 15 grains of table salt, 2 milligrams. Carfentanil is way worse than that. Carfentanil is really very, very toxic. And then you got everything else. And as far as identifications, we're seeing overdoses that are reversed with naloxone, but when it comes to forensics, there's actually a law that was just introduced in California. Excuse me. There was a death there, and the law is going to require testing for fentanyl and fentanyl analogs and overdoses, because getting a test that shows whatever it is that somebody overdosed on is not that simple. It's actually pretty complex. The toxicology, it's a very dynamic game. So I think the point of the community is these molecules are out there and they're very deadly. And I'll talk at some point, hopefully, about the counterfeit problem.
We'll get to that in just a
Yeah.
second, but I want to talk to Chloe a little bit about some living in recovery and living here in this community. And we're seeing not only the overdoses come down, we're seeing a lot of different techniques, a lot of intervention, a lot of prevention as a community, but as someone in recovery, what are some of those key ingredients that you have found for yourself that have been effective, but also that you are finding effective in the community that you live?
I think we have an amazing recovery community here in Martin County, and there are a lot of treatment facilities, a lot of transitional housing. We have a building that's dedicated to meetings all day, every day, Fellowship Hall here in Stewart. And we have everything we need here locally, and I think wherever you are, if and when you're ready to get sober.
And for you, was there any certain catalyst that the community provided that helped you in that journey?
Well, I went to treatment and then immediately started a 12-step program and got as involved as I possibly could in the program and with fellow people in recovery, and that was extremely helpful for me.
And in the recovery community, how are those living in recovery, working within this new landscape of, the substance world we live in is a little bit different. It keeps changing. Again, we talk about the lethality of it, if you will. But how is the recovery community embracing this new challenge as a community?
Well, I think that there is a lot of opportunity, no matter what challenges we face here locally. And a lot of friends that I have in recovery are getting into the treatment industry, which I think is really helpful for people in a lot of different ways. And becoming sponsors, sponsoring people, just really reaching out to that community however we can.
Wonderful. Thank you.
Thank you.
And Dr. Marshall, when looking at the behavioral component, we were having a little conversation prior to this, and this is a big picture. Not only is the opiate crisis sort of the acute, but it's based on a whole number of factors that lead someone to that. In your mind, what are some of the other risk factors that you're seeing with your clients, especially younger clients? Because fortunately, we see opioids not as a heavy use item in youth, especially in Martin County. It's almost imperceptible as far as data sets goes. But we also know that once we reach adulthood, we see those issues. So what are some of the things you're seeing that could be risk factors for our young people and families? And then we'll pivot more to some of the protective factors.
Sure. Well, certainly any type of mental health concern that's perhaps not diagnosed or not being healed in the moment, that could definitely be a risk factor for later on use. Family history, and the caveat to that is does anyone know anyone that doesn't have at least one family member who has struggled with, addictions of one way or another? Also, family conflict issues such as that, significant trauma in their lives. I believe that there's a large percentage of individuals that are in the disease of addiction that do have a trauma history. So that certainly can relate to that. I think that off the top of my head, those are probably the main, issues that of concern. One of the things, though, that it also concerns me is that this parent idea of, well, that not my child, and never my child. And then I would like to say to those parents, well, then whose child, right? Because, certainly there's no bias here when it comes to whether or not someone's going to end up being addicted or not. And I recently saw that through the Florida Youth Substance Abuse Survey, when asked the question of have your parents spoken to you about prescription drugs, and alarmingly, I think it was like 78% of the children said no. And I think that parents do need to start having that conversation, and not necessarily a scare tactic, but even watching things such as this and having a conversation about it afterwards. So I think that is probably one of the biggest preventative tools that we have at our advantage, is parents having that conversation and keeping that door open to having further conversations.
Now, looking at intervention as well, because obviously Tykes and Teens providing counseling and support services there. What are some of the areas of need you're seeing, especially in our young people? What are some of the areas that you're finding are most prevalent right now?
Yeah. Well, depression and anxiety, and I know I've heard people have heard me say this before, that's probably some of the biggest presenting issues that we have. But most recently, it seems as though we have families that have more convoluted situations where we're really needing not just the therapist involved, but might be needing a case manager involved. Housing is a huge issue for a lot of families right now. So I would say a lot of complex cases where we're needing to involve other resources. So that is a huge need. We also have a mental health consultation program where we have individuals, specialists coming into pre-K services and helping the teachers from a trauma-informed lens support the little ones. But through COVID, we're seeing that we're having a lot of children, little ones in those programs that haven't been socialized. So the behaviors in that environment have risen dramatically, the negative behaviors, which research shows that a child that, and it does sound perhaps, unbelievable to some people, but like that does set a child to a trajectory of further issues, whether it's, at pre-K and then later on in grade school and then later on, in adults. So that can be, a huge prevention tool if we, came in and were able to support those children in that way.
And would those be related to, say, ACEs scores, adverse childhood experiential scores, those types of things? Or is that a tool that's utilized to, I know it's a tool, there's many out there, but to sort of assess that risk profile for some children?
Sure, we can use that, but however, what we find is that there's a lot of underreporting when you first meet an individual and you show them the ACE tool and, tell us what kind of trauma you have had. So there's a lot of times underreporting, and it's not until we really get in there with an individual that we get to see like the full profile of where have they come from.
And I think that's important that people understand these things. None of what we discussed tonight lives in isolation from others. It's all interconnected. And when you talk about families, the stressors that they're under, and certainly the challenges that we're seeing around the community, housing, economics, those types of things, inflation, it's there. These are stressors, and stressors on the community. And Captain Dowdy, I was curious, are you seeing some other trends in the community related to those types of issues that, maybe certain spikes of other types of activity that are related to that? Because, again, depression, anxiety usually leads to substance use, other criminal activities, things like that. Are you seeing some fallout from those situations yet?
We do. Unfortunately, in law enforcement, we see fallout from many things, and it comes and it goes, and we see where the drug trend goes one direction, and the doc's going to talk about shortly. He's going to talk about designer drugs. We see where it falls out, and they move away from one and come to another. We see in our homeless populations, we see drug use. It does. Everything touches from one to another. So it's constantly changing and evolving for us, and we're constantly. It seems like there's times though that we go back and handle the original problem, that something's come back, and in the meantime, we're still trying to figure out this one. So there's always something going on.
And I know that there's been programs with the sheriff's office engaging behavioral health professionals to go along with deputies as they respond to calls. Can you speak a little more to that? Because I know that that's been in actually one of the things we talked about a few years ago being implemented, and curious to see where that has going and how that's been working for the sheriff's office.
It actually has been working. When I first came to our first board a couple of years ago, we were just creating the behavioral health unit. It's not fully staffed. It is staffed. We have a great crew of sergeants and deputies and behavioral specialists that's in that unit. They're used quite a bit. They have reduced the calls for service on our daily road patrol deputies, and I see that law enforcement is trending that way. There's calls that those guys are specialists that they've made contacts within the county. They know Michelle Miller, they know everyone, and they're working to where the typical road officer couldn't do it. These guys are actually making those contacts, and it's more of a one-on-one. As the doctor said, they're not a counselor, they're not, your life coach, but they do know the people. When they hear the calls, they're able to get out and get involved in them and help get them back on the right path or lead them down the path that they need to be on. I think it's something that we're going to see more agencies become involved in. A lot of others have. If you look at Central Florida, the Orange County Sheriff's Office has a huge behavioral health, mental health unit. And I see that's the trend, that we're not only are we on that path, but we're eventually going to try and stay on it and widen the path.
And that goes back to that being proactive in a community to be prepared for what is to come. I think that's where Jay was alluding to when we talk about the fentanyl situation that we're in, and truly, it really is not an emergent issue anymore. It's our daily situation we're dealing with. But looking at some of those other synthetic components and other things that, and I know that we discuss other synthetics, other two pieces of this. One, some of the areas that you're seeing development, and number two, let's start looking at sort of the treatment and getting into the recovery space, how the medicated assisted supports are actually an important part to the recovery journey for many as well. I kind of wanted to go both places because there's been great work that's been happening in both.
Yeah, so whatever synthetic comes along, and like I said, there's over 1,000. So you could pretty much figure that something new is going to show up. The fundamental recovery ideas cover everything. If it's an opioid, and we're not talking about stimulants like, methamphetamine or cocaine. This is a session about opioids, but so it's like a weaving together several different approaches. Medications are important. And those medications would be buprenorphine, which is known as Suboxone or Subutex or Zubsolv. There's several different names. So buprenorphine is an important medication in certain individuals. Naltrexone is another one. So that is an opioid blocker, and then also methadone. Now, how these medications, there's very, very solid data that shows that these medications are life-saving in certain instances. But not everybody's recovery looks the same. Some people, one of the problems is, even though these medications, and I don't want to just say Suboxone, I want to say buprenorphine because of all the different forms of it. These medications stabilize individuals. They allow them to function, and they help prevent relapse. There is extremely strong data that shows that overall mortality, so death from all causes, death from overdose specifically, and then also just overall outcome can be greatly enhanced by buprenorphine. However, that's not the only way to recover. And I've had a lot of really good conversations with NA. I'm friends with them. Their world headquarters outside of Van Nuys. We met in Atlanta. There's a tremendous controversy right now amongst individuals that are in recovery. I'm part of the community here, Celebrate Recovery, faith-based, peer-to-peer community groups are extremely effective and very powerful. But inside of that, the role of medications is very contentious, and it's very difficult to sort out. What works for one person doesn't work for another. The other thing is buprenorphine is threatening to a lot of individuals in recovery who view it as a doorway to relapse. A lot of individuals in recovery have, come face to face with death. They've been in intensive care units. They've lost everything, their families, and the last thing they want to do is be around something that is going to threaten their recovery. So they fight as if they're fighting for their lives. And one of the things they fight against is buprenorphine. Now, not everybody's like that, but I can tell you there's a huge problem. I know people who have died from overdoses because they've been pushed off of buprenorphine by loved ones, by family that's like, oh, you can't see the baby if you're on Suboxone or buprenorphine. You can't come in the house or whatever. I understand where that's coming from, and it's a very complex issue, but it's not really the buprenorphine that is a fundamental problem that I see it. It's the disease is very cunning, and it's very tenacious, and people, just because they're on buprenorphine doesn't mean they're gonna, everything's gonna clean up. And I think it's, to get back to the idea about medications that you mentioned, naltrexone has data, so it's Vivitrol. There's, and of course, methadone. Methadone programs kind of faded away in the last couple of years, displaced by buprenorphine. However, they're coming back right now in a very kind of on the down low, quiet. But I don't want anybody to try and again, I say this with a lot of difficulty because I know a lot of people that are in NA and how life-saving that is, and I'm very much in favor of that. But there's a lot of critics of 12 steps also, cults. You can find people that will criticize anything, but we're talking about people surviving here and restoring them to a place in their families, in the communities, in their lives. And then there's harm reduction. That's a whole nother can of worms, so, that's getting to be a real battle cry right now. And that is allowing an individual the right to continue to use drugs, but to do so in a way that minimizes their risk of a medical event like death and maximizes their ability to engage socially and in a community setting. We could talk for hours on this.
And I think one of the things you bring up, two critical points. One, the idea of truly individualized recovery. Recovery is an individual journey. And secondly, this concept of the system of care, a recovery-oriented system of care. There's all kinds of components to it. And there's not one that's more important than the other. They all have to work in concert to support an individual and an individual to engage in. And looking at how Martin County is building itself, This is kind of a question for Chloe as well. Are you seeing that this county is creating that recovery-oriented system of care where the individual is valued in that recovery space? And if you're seeing that, maybe some ways you're seeing that, and maybe some ways that the community can embrace it differently.
Yes, 100%. I think that recovery is possible for everyone, and all of the options that we have out there now, as well as online, but in person, give us the opportunity to follow a new program. Like it was said, Celebrate Recovery. There are churches, there are many different meetings, there are people that host things in their home. We just have an amazing community here in terms of recovery, and I believe it's possible for everyone.
And I wanted to give some more for the community here, too. When loved ones are engaged or seeing something happen, Chief Campbell, what can families be looking for in their loved ones or friends, family, or out in the community that's going to indicate that something's not right? And, because you roll up on the scene, something's happened. What can people be looking for so they can either make sure that they're supporting that person with, if they have naloxone, or also engaging 911 and engaging fire rescue?
If they find changes in behavior that are dramatic, and that's what, from an emergency standpoint, it's going to be very dramatic changes in behavior. Maybe you can compare it to somebody who maybe, who had too much alcohol, but to the point of unconsciousness, slurring of speech, the inability to actually, focus on anything. But usually what we find is when we get involved, they're unconscious and unresponsive. So that's a very dramatic change from what's normal, and they're unable to be aroused. And in that case, if somebody does have leave behind Narcan, it's paramount at that point. Even if it's not a narcotic, you can give this Narcan that goes into the nostrils, and you can give it. It doesn't have any effect on anything other than blocking the effects of an opioid. So it's a very safe medication to use in those kind of circumstances. So behavior that's that dramatic is really dramatic mood shifts, changes in behavior, and just the ability to function physically. That's what I would look for from an emergency standpoint. For kids, you're looking for changes in their behavior, changes in what's normal for them, different friends, and however that progresses. The biggest thing I've seen thus far, and what I think really contributes to the success we've had in Martin County, is the last 3 or 4 years, we're doing things like this, our third one of these, and this is hugely important because it increases awareness and gets all of us in a room working together. I know they have some really good programs going on with the schools right now with mental health and mental health counseling that's just not just focused on mental health, but also the use of substances that's inappropriate for kids, from vapes to marijuana, et cetera. And I think those are having a huge impact. And I have friends who actually work for the school system that do that, and they tell me about the impacts that they are having. It's pretty impressive. What's happening with the sheriff's office, what they do in the jail. You got Volunteers in Medicine. You've got Janan Wasina, who's a doctor locally who works really hard to work with children's mental health. And I think all of these different programs are working to the same goal. And I think that the reason we're seeing the effects right now is because of all the hard work from a lot of really hardworking people.
And that, again, creates that community.
Absolutely. Yeah.
That makes a huge difference. In your work, Chief Campbell, too, are there other interventions that you are now using medically that are making a difference as well? We know naloxone is a great tool. Are there other techniques or things that are being adopted that you're finding to be effective as well?
Well, we share, because it's within the same BOCC or the department, we share information with the OD2A with Michelle Miller from Human Resources. And she works with Maria Valls to make contact with everybody who we make contact with who may have overdosed. And they extend as much help as they can to them. I know Cleveland Clinic has MAT in their ERs now, and that was something we fought for a couple of years ago. We have an MAT clinic, which is medical assisted treatment, the Suboxone, the medications doctor was talking about. We have a clinic in the county now who works with Cleveland Clinic. And so it's a different approach to how things are done. It's one more tool in the toolbox. And you combine that, I think a lot of this has to do, it's a mental health disorder in many ways. And the fact that it's so many different, it's so much more on the forefront, and people are looking at it and recognizing it and approaching it from so many different ways, it's definitely having an effect now.
And Dr. Marshall, as Chief Kim was talking about some of the work that's happening in the schools. Tax and Teens does a lot of work with the schools and in the schools. What are some of the programs that you're seeing are being effective with our school-age children? And that's, of course, from pre-K to high school. You cover the gamut. So looking at that field, what are some of the things that are being implemented, and how are you seeing those work?
Well, I think with our therapists, a lot of our therapists are actually in the schools, so we're kind of removing the any barrier as far as transportation is concerned, and we're meeting the children where they're at. And we've been in the Martin County schools for several years now, and we're actually not K through 18. We're actually 0 through 18 because we do infant mental health. A lot of our referrals for infant mental health come from DCF on families that have suffered trauma one way or another, and we do a specialized treatment called CPP, child parent psychotherapy, that kind of helps that baby brain heal from trauma early on so that we don't have further issues later. And of course, our outpatient office, we offer telehealth services as well. Again, our goal is to remove a barrier, whether it's physical, whether getting to the appointment is difficult, or monetary. We have a sliding scale set up that our goal is always to allow there not to be any barriers for a child being able to have help in one way or another.
And Chloe, if you are engaging someone that maybe that's saying, hey, I'm ready for recovery, what are some of the best ways you find to bring people into that space?
I think there are several ways to go about it. You definitely want to mentor people when you can, and give the best advice you can, or share your mentors with them, which I have a lot of great ones. And those are very serious about recovery. I definitely recommend getting into treatment or getting on a medication that will help them overcome that. And then from there, perhaps transitional housing, a halfway home. There are many of them in our area. And then working the program, I know it works. It's worked for a very long time, and it's proven. And so it's available to everyone.
And you mentioned treatment. We talk about treatment. We say it. It's like the big word. It's almost like when we say Suboxone and when we say fentanyl. It's like a big blanket term. I like what Dr. Kuchera was saying. It's, we got a fleet of vehicles that covers it. But for you, and maybe to explain to folks, maybe they don't understand maybe what a treatment for substance use disorder may look like, what are some of the things that people need to be looking for in a treatment environment?
A treatment facility that offers a detox program that can go anywhere from 24 hours to 72 hours, and then 28-day programs. I did a 28-day program. I've heard of programs that go three months to 2 or 3 years, depending on what you're really looking for. There are a lot of options here in Martin County and in our surrounding counties, so it's available for everyone that's ready.
And you also mentioned in our conversations too, and again, congratulations on completing the drug court program, which is tremendous.
Thank you.
But that is another barrier, as Dr. Marshall kind of alluded to, some barriers. For some people, there may be legal barriers to either getting into support or it's the catalyst for support. Could you explain a little bit about the drug court program so people may want to take advantage of that opportunity?
Yes, the drug court program seems a little bit intimidating at first. It is drug and alcohol testing up to 7 days a week for a year or longer. But the team behind it is so amazing, and the structure that it provides for people that so desperately need that kind of structure is, I think, it definitely played a part. I know it played a part in saving my life, and I would recommend it to anybody that has the opportunity to do it. It's totally worth it and helps you build the foundation that you need to live a happy, healthy, sober life.
As we look at this community, and I'll be rude here because I spread my things all over this desk here, but look, being astute with time here. But what Chloe's talking about, again, getting the individual the help they need, the support they need, and understanding some of these nuances, if you will, is really critical, especially for the public, because even though we've been doing these forums and increasing the education, there's still a lot of people that this is still foreign to them. They might be watching this for the first time, or it's something that their family immediately hasn't encountered, and suddenly they find themselves in it. So making these things accessible and being aware of them is really important. So, Dr. Kuchera, when you hear MAT, a lot of these terms are like alphabet soup, right? And people hear them, and we could take them for granted because we know these things. But for the public, can you explain a little bit more about medication-assisted and medically assisted treatment modalities, and what does that mean for an individual?
Well, to further confuse things and make this a difficult conversation, the terminology has shifted. So now they've gone to medications for opioid use disorder. And that was such a kind of tricky little switch because the term MAT, just like the term Suboxone, got deeply ingrained in not just popular lay public conversation, but also amongst healthcare systems. And I just had this conversation with a large healthcare system who continues to refer to medications as MAT. But I'm also an addiction medicine specialist, and I've been in, what I was saying earlier today in a meeting is I've been swimming in a very small fishbowl of addiction medicine specialists. There's about 4,000 to 5,000, or actually 2,000 in the United States. And so anyway, the term that you're probably not going to hear is MOUD, medications for opioid use disorder, and that would be buprenorphine, naltrexone, and methadone. MAT, medication-assisted treatment, or there's a couple of other spins on that. The idea there is that the medications assist the treatment of an opioid disorder, so the behavioral treatments you hear about, and that could be one-on-one therapies, group therapies, faith-based community therapies. There's smart recovery, which is non-faith-based, peer-to-peer community groups. And when I say peer-to-peer, I mean one person has lived experience connecting with another person in a way that is incredibly powerful when that connection happens, because the trust that happens there, because it comes from inside of that group. And I could, get off the track here, getting back to where we're at with MAT. I cringe when I hear that because it's been drummed into me in the literature, in the technical literature, in the meetings that we go to, and listening to all the cutting edge data. MOUD, I don't think the community's going to hear that. So medications, just to try and get back to some cohesive statement here. So medications for medication-assisted treatment, MAT involves medications and then some form of therapy. There's an idea out there that has data that you don't need to have the behavioral component, that just the medications alone are associated with positive outcomes. If you look at large population outcome studies, personally, I don't particularly buy that. I think the reason that there's a push to say, look, just get an individual the medications, because a lot of individuals, probably 2 out of 3 people that set foot in a room, like a NA meeting, will go back. Only about 1 in 3 or less that even walk in the door will feel comfortable in that particular setting. So I think the fundamental idea here is to not say you can't have buprenorphine unless you're engaged in therapy or unless you're engaged in a recovery group, which, by the way, doesn't really like buprenorphine in general. So yeah, it's a strange idea. Just get the person the buprenorphine or the naltrexone and see what's happening. That's one way of looking at things. But to go back to this idea overarching is not every person recovers the same way. Everybody recovers differently. And, to have as much tolerance and as much of the system that is flexible, that can meet each individual at their point of need. So nobody gets pushed out. Nobody gets left behind. If somebody wants to do, NA or meetings or celebrate recovery and that's it, and not medications, fine. If they want to do treatment, that's fine. Whatever works, MAT is, like I said, I cringe, but 99% of the population won't. If you hear MAT, you're going to think Suboxone, which is buprenorphine, and other medications, or naltrexone, less commonly used, which is Vivitrol, which is usually given by injection every few weeks, and then also methadone, which is the classic methadone program where you present usually once a day or every few days.
And I appreciate the understanding. It also shows the changing and evolution of this issue. And usually by the time the public catches up to the medicine or the profession, we have new learning to do, and that's certainly anticipated. I'm just curious, though, with MOUD especially, has there been challenges even in administering MOUDs with the increased intensity of the synthetic opiates? Are we seeing are traditional detox regimens appropriate enough? Or we need to see changes? Or how are we going to adapt that environment for the change of these substances? Because we all know, it's the intensity. Heroin versus carfentanil is two different universes of intensity and lethality in certain ways.
Somebody that's been using fentanyl or synthetic analogs, it's more challenging to initiate buprenorphine. That medication just seems to stick around a lot, and we're having more problems with putting a person in a withdrawal state. And I don't want to get too technical about it because there's a lot of academic work right now and studies that are coming out that are looking at this in a much more detailed manner. But just in general for the average person, the synthetics like fentanyl and fentanyl analogs are making buprenorphine more challenging. Naltrexone I don't know much about because it just doesn't seem to be used that much.
And it's just a curiosity because as people look for treatment and look for opportunities to get well, we want to make sure that all assets are being utilized, and also, again, what is being most effective for each individual is critical. We're actually about ready to wind up here. And did we have a question?
We have a question on Facebook.
My screen has gone blank. So
We have a question on Facebook about health insurance and treatment options, or lack of health insurance, and what treatment options are available in our community.
I'll actually direct that to Dr. Marshall as far as looking at that. And that's a big question that comes up a lot, and certainly Dr. Kuchera can speak to that too. But when it comes to insurance and opportunities for getting loved ones help, what are some of the paths people can utilize, and also what are some of the challenges that you're seeing with certain plans, et cetera?
There seems to be like this in-between population where they don't qualify necessarily for Medicaid or those type of assistance, but they also may not be able to have the means to have a regular private insurance. So those are the people that really we feel for when it comes to adults. But we do have a lot of great organizations that do sliding fee scales with adults as well. And Catholic Charities certainly is a great organization that has low-cost treatment. When it comes to the more intense treatments, whether it's residential or intensive outpatient, that gets a little bit trickier. I know of some local places that do payment plans with individuals that don't have necessarily the means to pay for that kind of service. When it comes to children, we are a lot better at taking care of our children's mental health in this community, unfortunately, than we are adults that are in that in-between group. But certainly, as she was saying, that there's more than one pathway to recovery, and I'm just really excited that there are so many other options, and we've shifted to so many other options. Peer-to-peer, I think, is wonderful. I think it's worked amazing, and certainly I believe that you can receive at no cost. So yeah, there's so many other options, but we do have some work to do when it comes to access with that population. But there are some great things happening as far as, in our community, we have the Martin County CHIP program where we have subcommittees where we're trying to identify a list of the providers in our community, and as well as enlist other providers in, can you do a pro bono here, or how many beds can you do on a scholarship and things like that. So there are movement being made to be able to have that in our community.
And I won't speak for some of our other members aren't joining us on the panel tonight, but the community is strong. And when people do present that they need support, generally it can be found. It may not be exactly what you were looking for initially, but there's a very strong community here that can absorb and support that. Of course, we wish it was more robust. Who wouldn't? But I think you explained it very well. As far as sort of the technical, I'm not an insurance person, but please, one thing we do encourage people to do is actually really look when you're signing up for insurance. You really do need to look at your policies, really need to go through each thing comprehensively, because what you think you may have, you may wind up not having when it comes to actually time to receive care for certain things. So please just work through that with your providers as well. But as far as reaching out for services, this county, as you've heard this evening, they've put this in the forefront. Not only approaching the opioid issue in this county and trying to get ahead of it as opposed to getting behind it. There are resources available, certainly through the Martin County Department of Health and Human Services, which helped put this on tonight. There are access points right there. Certainly the 12-step and fellowship community is very, very strong here in Martin County. Our Celebrate Recovery community is very, very strong. You've certainly heard from our public safety, our fire rescue, that they are out there on the front lines looking at this compassionately, professionally, and doing that to the best need of each individual and family. So as we go into our next year, this has kind of become a tradition. We get together, we look at sort of the state of the state. You can hear the change in tone if you've been listening to these over the past few years, where in the beginning we looked at what are we going to be doing? And we've implemented so many different strategies and so many partners have come together. We're seeing the difference that makes daily. We're seeing those numbers come down. Any one number is more than enough. But to see that shows change, shows the opportunities that people have here. So for those out in the community, we can thank you enough for joining us tonight. We look forward to seeing you again next year. We hope to bring more positive news, also hopefully some more resources and understanding of this ever-changing issue. But for this year, we thank you for joining us. And please, if you know someone that needs help, please reach out, certainly to Martin County Department of Health and Human Services and any of these other organizations that can be found on the website. Please join us next time when we get together. Thank you again.